Hello and welcome in the discussion of the INI-CET recall, which came from the question that came from the orthopedics. I am Dr. Yusuf Ali Tyagi and we are going to have a discussion on this recall session. You know, the questions which were asked in orthopedics in this INI-CET examination were not out of the box. All those questions, all those topics, all those concepts which they were asking for the last multiple years, the difference in the languages, the difference in the way of portrayal those questions were asked in the same way or in the same manner. All right. The first question, simplest of the forms, like the patient came with difficulty in extending the distal interphalangeal joint of the medial two fingers. That means the interphalangeal joint extension is lost in the patient, and injury to which of the following marked structure will result in inability to hold the paper in between the fingers. If the patient is not able to hold the paper in between the fingers. So basically, what the examiner is asking about is the card test. All of you are aware of this, that inability to hold the card in between the fingers is card test. And card test is basically the assessment of the finger adductors. Like imagine if this is the card, ask a patient to hold the card in between the fingers, while as an examiner you try to pull this out, ask the patient to apply the resistance. If the patient is able to apply resistance, card test is negative. If you can easily pull this card out, the patient is not able to hold it properly, card test is positive. Understood? And that card test is for the assessment of adductors of the fingers. Adductors of the fingers are basically the palmar interossei. And these palmar interossei are supplied by the ulnar nerve. So there is nothing new which was asked. Hundreds of the time this question has been asked. Now, once you are aware of this card test, another finding which is provided to you in the question is inability to extend the interphalangeal joint of the finger. You know, extension of the interphalangeal joint of all four fingers is the function of lumbricals, and medial two lumbricals are also supplied by ulnar nerve. So when the patient is having a difficulty in extending the interphalangeal joint of medial two finger, it is basically the medial two lumbricals, the function is lost, and lumbricals are also supplied by the ulnar nerve. Now the examiner is asking you to correlate that where exactly the bone is going to have an injury which will impact the ulnar nerve injury, as a result of which these changes will be ensued in the patient. So if there are several of these structures marked, like proximal end of the humerus, if mid shaft of the humerus, the lateral epicondyle of the humerus, or the medial epicondyle of the, this is medial epicondyle of the humerus, or the lateral epicondyle of the humerus. If these are the structures marked, then obviously the answer for your question is the medial epicondyle. So this is how the examiner is trying to correlate the findings with the injury. Because the injury around the medial epicondyle, all of you know that the nerve is lying posterior to the medial epicondyle. The ulnar nerve is going posterior to the medial epicondyle. And if there is a fracture over here, if there is an injury, if there is a dislocation, then it might impinge the ulnar nerve activities, as a result of which these are the clinical findings. So straight away the question is, answer for that question is medial epicondyle. All of you are aware, like if there is a fracture in the proximal aspect of the humerus, it will result in the axillary nerve injury. If there is a fracture or the injury in the mid 1/3 of the humerus or the humerus shaft, then it will result in the radial nerve injury. And if there is a fracture in the medial epicondyle, it will result in the ulnar nerve injury. So it is in general. And as far as children are concerned, the lateral condylar fractures are going to have the impact on the ulnar nerve as a late complication. Supracondylar fractures are responsible for injuring the anterior interosseous branch of the median nerve. So these are the other facts which are related to the fractures around the elbow joint in case of a child. Here the question is simple and the answer for that question is straightforward. Next question. In the last year, when we were talking about the expected questions, because one of the question is asked that how to manage the patient immediately if you see him in the emergency. All right. If you see the patient in the emergency, then how to manage him immediately. This is what they are asking again and again. So on the basis of that, pelvic injury is something which has to be managed in the emergency itself, because it is a condition that could be observed as a life-threatening to the patient. Just imagine how. If there is a pelvic fracture, and in case of a pelvic fracture, because it is a cancellous bone, it will result in massive bleeding. So there's going to be a massive bleed. All right. And the patient obviously will come in shock. Though there could be other associated injuries, like there could be a bladder injury. There could be an injury to the bladder possible. All right. So these are the fractures, and how to manage them immediately. The examiner is asking about the immediate management, that what is the first step that you will do when you are suspecting the patient to be suffering from the pelvic fractures. So if the patient is presented to the emergency with the pelvic instability post road traffic accident, what will be the first step in the management? Now, the first step in the management is to compress all the pelvic bones, all right, to apply an external compressive force in order to hold the pelvic bones together in order to prevent this bleeding which is happening from the cancellous bone. All right. So in order to hold the pelvic bone, in order to bind the pelvic bone around, there is a pelvic binder. So pelvic binder is used. So what are the steps? First, you will apply this pelvic binder, and obviously you will go for the management of the shock. If the patient is having a shock, that means you will transfuse the blood. Whatever is required, you will get the x-rays done. You will stabilize the patient. Subsequently, once the patient is stabilized, then you have to put the traction. So, but the first thing is to limit this loss of blood. And this limitation of the loss of blood can be achieved by the pelvic binder. But you know, in this questions or in this options, the options are definite internal fixation. Obviously, you can go with the definite internal fixation, but in the later management course. All right. One, you have to stabilize the patient. Second, external fixation. Yes, again, external fixation is a primary management in order to compress the pelvic bones, but that external fixation requires spinal anesthesia to be given. And if the patient is in shock, then this spinal anesthesia will further lower down the blood pressure of the patient. So basically, external fixation is a procedure to be carried out in the emergency operation theatre, but the examiner is asking what first you have to do, even before the application of this external fixation. Blood transfusion, obviously, yes. Once you see the patient, he is in shock, you will get this blood to get arranged, all right? You arrange the blood to get it replaced because of the massive blood loss. But again, the question remains the same, that what is the first thing that you will do? The first thing that you have to do is bind the pelvis. And if you are not having that pelvic binder, then drape the bed sheet around. All right. You have to drape the bed sheet and apply compression at the pelvic bones in order to prevent the bleeding from these cancellous bones. So, generalized question, you know, just using your common sense, you can answer this question. And we have been giving importance. We are giving the importance to these type of the questions. Like one question from the emergency setting is going to be asked in this INI and the NEET PG entrance examination. And in the last year, quick revision programs, we have discussed that how to manage the pelvic fractures, all right, immediately in the emergency. So this is how the question was asked. This is for the first time they have asked this question based on the common sense, all right. So you have to drape the bed sheet which is available and try to gain compression around the pelvis. All right. So hopefully these two questions are over. Next is that which of the following is a sign for malignant transformation of the tumor shown in the X-rays. Now, you know one thing that even in this, again, I would repeat my statement that in the revision program, we have talked about the osteochondroma lesion and exactly the options which are provided to you in the question. We talked about those questions. We talked about those options in the osteochondroma. Remember, osteochondroma is a kind of the tumor which is hot topic today. It is, first of all, it is not a kind of a tumor which is not identifiable. Just by looking at the X-ray, you can identify that this is osteochondroma. What are the specific features for that osteochondroma? So here what they are asking is that which of the following is a sign to suggest that this osteochondroma lesion has turned malignant. All right. Now, based on the options, if we go with the option number 1, increase in the cartilaginous cap thickness of more than 2 cm using an MRI. Yes, this is a sign. But before marking the correct answer down, we have to read the other options too. You know, the signs which are considered to be important that probably this osteochondroma lesion is turning out to be malignant. One of the signs is increase in the thickness of the cartilaginous cap. You know, this osteochondroma lesion is covered by the cartilaginous cap, although which is not appearing on the X-rays because you cannot see the soft tissues on the X-rays. Using an MRI, if the cartilaginous cap thickness is getting increased, that is one sign. Another sign, if there is increase in size of the tumor beyond skeletal maturity, that is another sign. If there is increase in the calcification of the tumor, a pre-existent tumor getting more and more thickly calcified, that is another sign. So these are the signs which are suggestive of that the tumor is going into malignancy or tumor is turning into a malignant tumor. But out of multiple signs, the most important sign which is considered is increase in the thickness of the cartilaginous cap beyond 1.5 centimeters. In the options provided, 2 centimeters given. That means this is the best possible answer for your question. Now, if you read the other options, like normally it grows away from the joint, but if it starts growing towards the joint, is it a sign of malignancy? No, because this basically is an exception where the tumor is going towards the epiphysis. You see what happens? Normally the tumor grows, or this is one of the characteristic finding for this osteochondroma tumor, that the tumor grows away from the joint, all right, away from the joint, not towards the joint. But in case if the tumor grows towards the joint, then it is a rare phenomena. It is an exception, and that exception is known by the name of Trevor disease, all right. So osteochondroma, which is growing towards the epiphysis, is known as Trevor disease. It is a rare phenomena. It has got nothing to do with the malignant changes. All right. So that is option number 2. So it is not a sign for malignant transformation. Then the third one is bone marrow continuity in the tumor and the parent bone. You know, normally osteochondroma is characterized by the continuity of the cortical margins. All right. If there is a continuity in the marrow, then it is osteochondroma. If there is no continuity in between the marrow canal of the parent bone and the tumor, it is probably not osteochondroma. It could be any other tumor. So this is also a normal phenomena which has got nothing to do with the malignant changes. All right. This is the normal finding, normal characteristic finding for osteochondroma lesion, that the bone marrow is always continuous in between, or the marrow canal is always continuous in between the tumor and the parent bone. So this option is a normal finding. Then developmental abnormality that ceases to grow beyond skeletal maturity. Yes, this is also true, but you know, it was considered to be a development abnormality. Today it is considered to be a true benign tumor. Osteochondroma, one of the characteristic finding is that the growth of the tumor, it stops beyond skeletal maturity. If the tumor continues to grow, it is a sign which is suggestive of malignant transformation. All right. So that is also a normal finding. So hopefully you get the answer for this question, that increase in the thickness of the cartilaginous cap is the answer for this particular question. That is point number 1. Now point number 2 is, that is again an important point. And that point is that, you know, this is not the first time they have asked this question. They have asked this question in 2015 examination also. And from there was a huge gap, like from 2015 up to 2023, this question never got repeated. But this question has been asked previously also. They have asked this question in the sense like, all of the following are the features of malignant transformation of the malignancy or malignant transformation of the osteochondromal lesion, except, so that was your question. And there also, an increase in the thickness of the cartilaginous cap was provided in the options. So this is not something new. All right. We have already talked about this. We also talked about the importance of this tumor. All right. Next, another question, which is directly a copy paste from the NEET PG examination, which was asked this year. Like, just look at the question, look at the x-rays. You already are aware of what the diagnosis for this particular question is. All right. The patient presented with the following abnormality on the x-ray. Now, what you see on the x-ray is, this is the normal side, obviously, and this is the abnormal side. Now, on the abnormal side, what is happening? There is a decrease in the neck shift angle to an extent that the greater trochanter is migrating proximal to the acetabulum. You see, if you look at the difference in between the levels of the greater trochanter and the acetabulum, then the GT is migrating proximal to, it has migrated proximal to the acetabulum without any discontinuity in the neck region or the intertrochanteric region. That means this is how you will identify the shaft of the femur or the part of the proximal femur is appearing like a crook, is appearing like a stick. All right. So it is appearing like a stick. And this is how it has gained its name, that is Shepherd-Crook deformity. Shepherd-Crook deformity. This is how it has achieved its name, that is Shepherd-Crook deformity. All right. All of you are aware of the fact that Shepherd-Crook deformity is a feature of polyostotic fibrous dysplasia. The most common fibrous dysplasia affecting the bone is the femur, the proximal aspect of the femur. It goes into Shepherd-Crook deformity kind of a deformity is happening over here. That is point number 1. Now, for those who are interested in knowing that why this thing happens in case of fibrous dysplasia, now you already are aware that the bone pathophysiological mechanism is that the normal bony cells All right. The progenitor cells are not getting differentiated into the bone cells. They are getting differentiated into the fibrous and a mixture of the bone cells. So abnormal bone is created. And this region is a weight bearing region of the bone. So if this region is the weight bearing region, on the medial side we are having a compressive cortex, on the lateral side we are having a tensile cortex, that means distractive cortex. If the strength of this bone is decreased because of fibrous dysplasia, then under the influence of the weight, what will happen? There will be more and more compression on the medial side. And because of more and more compression, it will get collapsed. There will be a collapsing more on the medial side. And the tensile will overgrow like this. So this is the reason for this Shepherd-Crook kind of a deformity that happens in case of patients who are suffering from fibrous dysplasia. Alright, so just by looking at the X-ray, you have already confirmed your diagnosis that it is fibrous dysplasia. But there are additional points which are provided in the question that will assist you in further confirming, consolidating your diagnosis. Like pale brown macules along with the pale brown macules over the skin, over the abdomen. Which of the following is the most likely diagnosis? So, the features of McCune-Albright syndrome, because polyostotic fibrous dysplasia, first of all, try to understand that polyostotic fibrous dysplasia is associated with two syndromes. One of the syndrome is McCune-Albright syndrome. And all of you are aware of what are the features of this McCune-Albright syndrome. One is polyostotic fibrous dysplasia, other one is café-au-lait spot, and the third one is precocious puberty. So it is a café-au-lait spot which is provided to you in the question, the pale brown macules over the skin, over the abdomen. Alright, X-ray features are also suggestive of polyostotic fibrous dysplasia. And the another syndrome with which it is found to be associated is Mazabraud syndrome, Mazabraud. Alright, Mazabraud syndrome. Now, this Mazabraud syndrome is basically polyostotic fibrous dysplasia and soft tissue myxomas. Alright. So, answer for this question is straight away. It is McCune-Albright syndrome for your particular question. Alright. So, this is the question which they have already asked. This is the question we have discussed in the revision program also. Alright. For this INI-CET examination, a straight away question. No difficulties. So, you came to know everything related to this particular question. Alright. Next. Again, a kind of a topic which we insist that you have to go with because it is a complication of the fracture that you have to identify. Alright. What else is required in the question when they have mentioned Peticki already in the question in order to make the diagnosis of fat embolism syndrome? Clear cut. What happens in fat embolism syndrome? Initially, there are alarming features. First of all, a patient who is having a long bone fracture is already admitted in your ward, is waiting to get surgery done. Now, what are the alarming features? One is fever, other one is tachypnea, and the third one is tachycardia. Tachycardia. Alright, fever, tachypnea, tachycardia, these are the clinical alarming features for fat embolism syndrome. Now, once there is a completion of these symptoms, then it might progress to the appearance of peticki, which are appearing over the trunk, which are appearing over the abdomen, even on the conjunctiva or the retina. Alright. So there are small bleeding spots which are appearing scattered over the abdomen, trunk, conjunctiva or retina. So these are the pathognomonic feature for fat embolism syndrome. As I'm saying it again and again, if you look at the question, what else is required for you to make the diagnosis of fat embolism syndrome? Like tibial fracture, long bone fracture. After 12 hours, he became unconscious. So you will come to know how this clinical profile goes from fever up to death of the patient. Axillary petechial lesions are present. Breathlessness is also present. What is the most likely diagnosis the patient is suffering from? So what happens? After that, there could be a feature of, because of the pulmonary emboli, there could be a feature of adult respiratory distress syndrome. Alright. So it might result in acute respiratory distress because of the pulmonary embolism. And even then, the patient might become comatose or it might result in death of the individual. So this is one of the complication of a long bone fracture where the fat emboli from the medullary canal reaches the circulation, resulting in the life-threatening event known by the name of fat embolism. All those clinical features are mentioned in your question. You just have to identify it and mark the answer as fat embolism for this particular question. All right. Not so difficult, right? Okay, so examination of hip, again I am saying, as I have already said, examination of hip, one question, directly or indirectly. Now what they have asked about over here, simple question, superior gluteal nerve is responsible for supplying. Answer for that question is gluteus medius and gluteus minimus. All right, so gluteus medius and gluteus minimus are the nerves which, are the muscles which are supplied by superior gluteal nerve. The gluteus maximus is supplied by inferior gluteal nerve. Now, why are they asking this question? They are not simply asking, they just don't want the basic assessment that you are aware of the nerve supply to these random muscles. No, it is a question which has got the significance. It is a question which has got the chains linked to the Trendelenburg test. All right. It has got the chain which are linked to Trendelenburg test. So this is how it will happen. Hopefully everything is clear related to this particular topic also, superior gluteal nerve. Now, yes, again a relevant question, and we are expecting this question. Means if you look at the basic anatomy, if this is the clavicular bone, already you are aware that this is the clavicular bone. This is a clavicle. Here we are having the proximal humerus. That means head of the humerus. This is the glenoid. All right, and this is the coracoid. This is the coracoid process, and this is the acromion process. So what happens is, basically there are ligaments which are responsible for providing this stability to the shoulder joint in between the acromion and the clavicular, known by the name of coracoacromial ligament. All right, there are ligaments in between the coracoid process and the clavicular bone which are known by the name of coracoclavicular ligament. Now what happens because of any injury to the shoulder joint or around the shoulder joint, if there is a tear in this, coracoacromial or claviculoacromial ligament or acromioclavicular ligament, then it will result in the inferior displacement of the acromion and superior displacement of the clavicular bone. All right, the clavicular bone will bulge. It will become more prominent because of the rupture of these ligaments. So answer is simple. What is happening over here in this X-ray? There is a disalignment in between the clavicle and the acromion process. Normally what happens? Normally how does it look like? Like if this is the acromion process, if this is the glenoid and this is the head of the humerus, all right, and this is the acromion process over here, and this is the clavicular bone. So this is how the clavicular acromion relations are. This is how they looks like. All right. And these are the acromioclavicular ligament because they are responsible for providing the horizontal stability, while the coracoacromial ligament is responsible for providing the vertical instability. As you can very clearly see in this particular question that these ligaments are already gone, but there is also a probability of the injury to the coracoacromial ligament. Now all we have to see, all we have to look for are the options which are provided in the question. Which of the following ligament is injured? Glenohumeral? No, because glenohumeral instability would result in the dislocations of the shoulder joint. Coracoacromial ligament is responsible for the horizontal stability, so it has got nothing to do with the vertical split. Glenoacromial is no such ligament like this. Acromioclavicular ligament, yes, is a probable answer, but associated with this, I would also suggest that there has to be an injury to the coracoclavicular ligament. All right, so both these two structures are injured, then there will be a insufficiency of these kind of the structures. It will result in the proximal migration of the clavicular bone in relation to the acromion process. So this was the question asked. They were asking about the ligaments which are likely to get injured with the given X-rays. On the X-ray, there was a dissociation, there was a dislocation, there was subluxation in between the clavicular bone and the acromion, and you have to identify the ligaments which are responsible for maintaining this stability. So hopefully everything is clear related to this particular session. As I am again repeating, you just have to confine yourself or you have to limit yourself in understanding the core concepts of a repeated multiple times asked questions, and you'll be done with the orthopedics. Thank you very much. All the best for your future.